So it's been a while since our last Topics of the Day webinar, and part of that was because it was summer, and part of it was because one of our main people, Adie, was in Rome presenting a poster, and so we could not proceed without her. And so apologies for taking so long in between webinar 1 and webinar 2. It is not ideal. So presenting again will be Adie and Geri, and we have a guest presenter joining us tonight, Leslyn Keith. And we could say a lot about her. I'm just going to read what she's willing to share, because most of us are, we don't like to toot our own horns. Leslyn's a certified lymphedema therapist and has a clinical doctorate in occupational therapy with an emphasis on lymphedema and obesity. She's treated lymphatic and fat disorders for over 20 years and currently researches, consults, and lectures nationally and internationally on lymphedema, lipedema, and obesity. She's also the author of 2 books, The Lymphatic Code, as well as the Ketogenic Solution for Lymphatic Disorders. And in her spare time, she's a director of research and board president for the Lipedema Project and an instructor in lymphedema therapy for close training and consulting. So tonight we're going to have a chance to both review some things, but a lot of new information. Leslyn's going to talk to us about what's new related to the brain and lymphatics, the revised Starling's equation, and lipedema. Adie Mackenzie from the Osher Center for Integrative Health at Vanderbilt Medical Center in Nashville is going to present the case study that she also did in Rome. And then ending the night, Geri is going to do her expertise, which is in researching resources for us on this topic. So I want to just give a couple of suggestions and a few house rules. So I always say when I start a class to people is just relax. There's going to be a lot of information presented tonight in a short period of time. You'll take in more if you're just relaxed and you know that there's a recording so you can go back and re-listen to this. So just, take some notes, but sit back and just let it come to you. You may also want to change the view setting in your screen, which is up at the top right. If you go to view and then hit speaker, it sometimes is helpful so that that's the only person that you're seeing. Interestingly, Ashley, I'm seeing you instead of speaker, which is fine. If you could wait until the end, we're going to devote 10 minutes to Q&A. And so rather than putting questions in the chat function as we go, but just write them down on paper. And then when we get ready to start the Q&A, I'll have you put them in the chat function. I will come back and moderate that portion of this. It's easier for us as presenters if we don't see the sort of like running line on the bottom of people having chat. If you just absolutely need to chat to a specific person that's here, then just chat to them and don't chat to everybody. So a big thanks for that. What was the other thing that I had in here? Oh yeah, I think that was it. So we do hope to stay on our time schedule, but no promises. But I'm going to be the timekeeper and we will do the best we can to stay on track here with our time. So I'll be back at the end to moderate the questions and then give you a few closing bits of information. So Leslyn, are you ready to take it away?
Sure. Yes, I am.
All right.
Thank you so much for having me here. I'm going to share this and put it into slideshow. There we go. I was so honored when Adie asked me if I would present for you and gave me seemingly disparate topics to discuss, but they actually all do go together. It's very cool. And I hope you guys are entertained and educated as we go through this stuff. Now, I do a couple of times, I might be asking for your response on what you think on various things. And so what I would like to suggest, just to make it easier for moderating and when we get to the Q&A, is just do a chat to me alone and not to everybody with your response. And I'm hoping, as with my screen share, that I'll be able to see what you say. But I like to keep everybody engaged and involved. So I might ask you a question. And so be ready on the chat and put it to go just to me. And let's see if that helps. Because I don't want you just to sit here and listen. I'd love for you to participate. So today we're going to talk about first the lymphatics of the brain and how that impacts your sleep, your cognition, and your overall lymphatic health, and how that impacts the brain. So I think that this is such a cool discovery, and I enjoy talking about this. And it may seem like it has no impact on the next topic, which it does, the glycocalyx. And so we'll talk about what that is and how that changed what we know about the function and the importance of both the cardiovascular and the lymphatic systems. And then we're going to talk about the revised Starling's equilibrium. And you may or may not know the original Starling, so we'll go over that first and then talk about how this has been updated, how that relates to the glycocalyx and the lymphatic system in general, and pretty much how it changed the importance of the lymphatic system. And then we're going to talk about lipedema a little bit and how your treatment would be different for lipedema versus lymphedema, but it does relate to the Starlings and the glycocalyx and the lymphatics of the brain. So it does all come together. And then I really hope I'll be able to come to speak with you again. And I discuss with Adie another topic that I'm very, very interested in, and that is the central lymphatics and what happens when those are not working right. And so I was going to give you a little sneak preview of what that might entail, that discussion might entail. So that is not part of when you take the quiz and all that kind of stuff for your CEUs. That's not part of that, but it's a little sneak preview. So let's talk about the discovery of the lymphatics in the brain. This was around 2012 when some new research decided that the brain and the central nervous system actually did have lymphatics that were involved in it. We previously thought that there was no lymphatics there. So you can see this initial diagram is pretty much the lymphatics went up into the base of the skull, but that was the extent of it. But now we know that actually it is throughout the brain and the central nervous system. So what is that special system? The lymphatic system and the meningeal lymphatic vessels, they are really responsible for removing waste and noxious material out of the brain. They're also important in delivering nutrients to the brain tissue in glucose, lipids, amino acids, and neurotransmitters. And then they also will be regulating that cerebral spinal fluid and interstitial fluid transport. It might also be really important for regulating neuroinflammation. And then, of course, it's got that immune surveillance function as well as our lymphatic system does for our whole body. So how does your lymphatic system deliver those nutrients to your brain tissue? So first, the arterial capillaries are going to deliver those nutrients to the choroid plexus inside the ventricles, inside the brain. So this is that arterial capillaries are right here in the ventricles. They're delivering it to the CSF, the cerebral spinal fluid that's in these ventricles. That's where the cerebral spinal fluid is produced. And then it is going to go to that subarachnoid space and and into those periarterial spaces, and I'll explain what those are in the next slide. But it's delivered in that cerebral spinal fluid into that, and then it's going to be pushed out from those the periarticular spaces and go into the brain tissue. And that, we got to talk about that a little bit, because that disseminating into here and taking it, and then taking the waste product out, and then getting it to the perivenous spaces, so the space around the veins, and then eventually leaving the brain tissue. So this is what I wanted to show you. So here is a capillary going into the brain tissue, and then there's this little space around that capillary that the feet of these glial cells or astrocytes, those brain cells, wrap around that capillary. And they wrap around the capillary and leave a little space, and that cerebral spinal fluid will go there, and then the nutrients will come out of the capillary and into that space. And then it is pushed out into this brain tissue here. And so it's flowing through that periovascular space, and then it's pushed out into the brain parenchyma, is just the brain tissue. And then it's moved through the brain tissue through the lymphatics. But it's kind of fuzzy on how that happens. So here's a schematic that is showing you that arterial capillary, and here's the venous capillary. You can see the space around that, both of those vascular vessels. And so now it's being pushed, the nutrients being pushed out here and somehow transported across to the venous capillary through the brain tissue. And it's very controversial. How is it moving across? Because what they found is diffusion would actually be too slow. So there's something else going on there, and they really think that it's probably there's some action of those glial cells that is facilitating that transport of that fluid across, delivering nutrients, and then simultaneously taking away waste and noxious material. And interesting, this is really cool. It's pretty much dependent on sleep, because those lymphatics pretty much don't function when you're in awake state. It needs sleep. Now, looking at the next part of that equation of how that brain is being serviced by lymphatics, we have to look at the meningeal lymphatic vessels. Basically, now we have something that looks like what we think lymphatic vessels look like. And so these vessels it's all being delivered through the parenchyma to these vessels that be then evacuated. And so you have that going to the perivenous space, and then it goes across the dura into these lymphatic vessels, and they're eventually going to get to the deep cervical lymph nodes in the neck, and now they're exiting. So now that's how we're evacuating all of that noxious material, waste material. But why is sleep so important? And you can see in this schematic that during sleep, we have some shrinkage of that brain tissue. And so it gives more space for the lymphatics to function and transport fluid. And so there is, and this doesn't even show as much of a difference it is. It's almost completely collapsed during the wake state. Sleep state, it's very dilated, there's lots of space, and we can really allow the waste and toxins to be effectively moved out of the brain tissue by the lymphatics. So you can see how proper sleep may be very important for prevention of those various neurodegenerative diseases. And interestingly, there was a great study that showed with Alzheimer's specifically that a high percentage of Alzheimer's patients actually had sleep disturbances that started well before onset of Alzheimer's symptoms. So you think about how important it is for your lymphatics to have enough sleep time to be dilated and be effective at removing all the waste materials to keep our brains healthy. So what happens when you get that lymphatic or meningeal vessel dysfunction. And there's really three main causes. I'm going to remove this so I can see my screen. Here we go. So the primary causes of having dysfunction in our lymphatics of our central nervous system is loss of sleep, aging. We're going to start getting a deterioration of functioning, and traumatic brain injury. So what that can do is you can end up with various types of dementias, ALS, multiple sclerosis, name a neurodegenerative disease, and these diseases, if you want to prevent those diseases, it really depends on healthy lymphatic and meningeal vessels. So how can we keep our brain lymphatics healthy? How can we help our clients and our patients? So good sleep hygiene, getting screened for sleep apnea and addressing it. Sleep position, there is some pretty weak evidence, mostly on animals, looking at sleep position, and what they're thinking is actually sleeping on your side, specifically your right side, may be very, very good for helping your lymphatics remove waste from your system, from your brain. So we can coach our patients on making sure that they're getting good sleep. Omega-3 fatty acid intake, either through food or supplementation. After that, it's really good for your brain health, but always consulting with their healthcare provider to make sure that this is okay for them to take. It's not going to interact badly with another medication they're taking. I think you're not supposed to take it if you're about to have surgery because of anticoagulation effects of day. So, but consider helping your patients increase their omega-3 intake. Ketosis. So that's the generation and the burning of ketones for fuel. And this can be accomplished either through fasting or through a ketogenic diet. Your brain really likes using ketones for fuel, and they can cross the blood-brain barrier. So this can be a very healthy thing for your brain. Of the two choices, fasting or a ketogenic diet, only one of them is sustainable. I'll let you decide which. Reducing alcohol intake. So we know that can have an unfavorable impact, alcohol, on both our lymphatics and our cardiovascular system. So helping your patients minimize alcohol intake is going to be healthy for their brain. Exercise, we know the impact that exercise has on our lymphatic system in general, and it's also going to have an impact on the lymphatics of our brain. And then what can we do to minimize chronic stress and helping our patients with that? I see that all of these things that as an oncology massage therapist, this can be all things that you'll work with. Well, of course, getting a massage is a great way of minimizing chronic stress. So these are all going to be good for their brain lymphatics. So moving on now to the glycocalyx, and we'll see how this all fits together. So let's talk about what is the glycocalyx, what's its function, and why is it important to the cardiovascular and lymphatic systems. So what is it? And this is a cross-section of a blood vessel, and you can see this lining to the blood vessel. It is a really hydrated and fibrous meshwork that lines blood vessels. It's kind of like I call it here a carpet. It's just this furry lining here. And on the outer part of it actually has this gel-like, very slippery layer. And then you have that furry carpet. And then below that, and it's not very well visualized here, but there is a space. So they call it a subglycocalyx space, a little area that can hold actually a lot of water, and it's used to replenish the system if it's needed. It can really generate a lot of fluid. And so this is really thanks to the electron microscopy that those kinds of photos, we couldn't see this before. We had no idea this existed. And so this is a pretty new discovery, and it really influenced what we're going to talk about next, was the Starling's equilibrium. We didn't know this was there. We didn't know that it was existing. So what does it do? Why is it important? And so this is a arterial capillary. You can see that it just has room for one red blood cell at a time to slip through there. And so that glycocalyx that's on the lining of the blood vessel really determines how permeable that blood vessel is. Besides the junctions, that the vessel wall, the cell junctions, we have different types of capillaries, and they each have different amounts of leakiness, because you want some places that are very, very leaky, and you want other places that are very tight junctions and doesn't leak. But besides that, those junctions, you also have the glycocalyx that is going to say, no, we don't want this to go out into the tissues, or so it really controls what can cross the blood vessel wall. And so, and they also, when I was talking about that slippery gel-like area, it keeps these red blood cells moving through and not getting stuck to the blood vessel wall, which can cause a lot of inflammation. And if there is some rubbing against the blood vessel wall, it produces nitric oxide. So that's doing that shear stress, or that rubbing against the wall. Nitric oxide is produced, and nitric oxide causes the blood vessel to dilate, so it has more room. So it's that glycocalyx regulates all that kind of stuff. And then, as I was saying, it's a reservoir for all that fluid. So, and this is a reason why diuretics, they will attack that fluid reservoir in the subglycocalyx space. They have no impact at all on the lymphatics. And so this is one of the main reason why we do not recommend using diuretics for someone with lymphedema, because it has no impact whatsoever on the lymphatic system. So what can damage the glycocalyx? Because here we see in this top schematic, very healthy glycocalyx, lots of nice furry carpet here. And here we have not much left, so quite damaged. What can do it? Well, hyperglycemia, high blood sugar, hypercholesterolemia, high cholesterol, hypervolemia, so extra volume of the blood, ischemia or reperfusion, so we're cutting off the circulation, trauma and inflammation. So these are the things that can damage that glycocalyx, and now we have no control to what leaks out into the tissue. So how is all this relevant to our patients who have lymphatic disorders, or we're trying to keep their lymphatic system healthy? And it does relate to it in the way of revised Starling's equilibrium. So let's talk about first the original Starling's equilibrium, which was developed in 1896 by Dr. Starling. He had no way to visualize anything that was happening. He did this all by testing pressures of inside the blood vessels and in the tissues. And he came up with quite a very elegant hypothesis, and it has been pretty much accepted for over 100 years, because the newest information came out with a paper that was published in 2010 by Levick and Michelle. And so from 1896 to 2010, this is what we all used. Most of your physicians that you will talk to, this is what they were trained in. And it's very slow to change to a new or revised way of thinking. And so many physicians are not on board with what I'm going to be showing you today. But I will tell you that your vascular specialists really are, because this is, what they study all the time. So let's look at those four forces. We got a force that's going to push fluid out into the tissues, and another force that is going to pull fluid, and they're going to pull from the tissue into the blood vessel and pull that stuff out into the tissue. So 2 ways to get the fluid from the blood vessel into the tissue. One's a push, one's a pull. And then we have 2 other opposing forces. Again, one is going to push fluid, Starling thought, into the vein, and one will pull fluid into the vein. So what they are is blood capillary pressure. So the pulsation from your heart sending the blood down to the capillary, that blood capillary pressure is going to push nutrients and material and stuff and fluid into the tissue. The other thing that's going to, then opposing that is going to be a push, interstitial fluid pressure. And this is where I would love to have you put something in the chat if you think you have an idea of what would increase the pressure of your tissues to help push fluid back into a blood vessel. So if you have any idea, if you have an idea what would increase interstitial fluid pressure, go ahead and put that into the chat. And then colloidal osmotic pressure of the plasma and of the interstitium. These are just fancy ways of talking about proteins. So we're talking about proteins in the blood or the plasma and proteins in the interstitium or in your tissues. So, and proteins attract water. So when I have a lot of plasma protein, it's going to attract water from the tissues into the blood vessel. So that is a pull, pulling it into the blood vessel. But if I have a lot of proteins in the tissues and not so much in the blood, now we're going to pull the fluid towards those proteins in the tissues. That's why someone who has low blood protein, low albumin, then that is going to cause us to have swelling because the protein in the tissues is drawing the fluid out, and we're going to get now swollen usually in the lower body because of that. So interstitial fluid pressure, the ways to increase it, well, it's exactly what you guys do, massage. So pressing on the tissues with massage, compression garments, that is going to increase interstitial fluid pressure and help push fluid, so Starling thought, into the vein. But let's look at the revision to this. So because he thought that 90% of the interstitial fluid really was absorbed into those veins and taken back to the heart, and the leftovers, about 10%, was evacuated by your lymphatics. But the revised system actually has a tremendous amount of importance on the lymphatic system, because now we know that almost all, pretty much 100% of the interstitial fluid is returned to the heart, to the, well, not to the heart, but to the major blood vessel just below the collarbone in the lymphatics. So that is what evacuates the fluid, not the veins. Mostly because of that glycocalyx, it is keeping on this tight junctions. It is not going to be absorbed in the veins. It's going to be absorbed by the lymphatics and transported to the circulatory system. And it's basically because of that, the lower pressure in the lymphatic system allows it to be an outlet for the interstitial fluid to get into, and all the debris and everything you want to evacuate it's into the lymphatic system, because of that lymphatic system is a lower pressure than the tissue. And it's really the difference in the pressure between the blood and that subglycocalyx space is more important than the blood pressure and the interstitial fluid pressure. So in the original Starlings, he felt that that interstitial fluid pressure that he measured and the blood pressure, that was what was creating the balance, but it's not that at all. And then that's what we're able to see, which started by Levick and Michelle in 2010, that they showed that it actually had more to do with the pressures in the vessel itself and between the glycocalyx and the vessel and with the glycocalyx. So very, very important. And now, because This is how all that fluid and waste gets back into blood circulation through the lymphatics. Our lymphatic system is pretty important. So just a schematic to kind of show those two, the classic Starling with those two opposing forces pushing and pulling, and revised, and the glycocalyx really coming into play, and how we view what's happening with our blood and lymphatic circulation. So let's talk a little bit about lipedema and how it is treated differently from lymphedema, and what we've already been discussing with the glycocalyx and Starling's equilibrium, and what's going on with the lymphatics of the central nervous system, how this all relates together. First, just a quick review. I think you've already had a presentation on lipedema, but I just wanted to restate the symptoms of lipedema and know what we're talking about here. So the most visible symptom of lipedema is that disproportionate but symmetrical deposits of fat to the lower body, and quite often to the arms as well. But it looks like almost like two different bodies. Usually the trunk can be unaffected, but that lower body can be very disproportionate. We can have non-pitting edema. Quite often there is an extreme hypersensitivity and chronic pain. The patient will bruise very, very easily. That has to do with our glycocalyx, right? And then there's going to be skin and tissue changes. So you can have lumps and bumps, these fatty fibrotic nodules, could be grain-sized or quite large in the areas of fat deposition. You can have cuffing, where that's where the fat abruptly stops just above the ankle, and you have this shoulder of tissue just above the unaffected feet. The tissue, and it's kind of not so obvious on this photograph, but it can be very little lumpy, mattress-like appearance, almost like what we call cellulite. We'll talk a little bit more about that when we talk about that fibrosis in there. So it can give that uneven, like a corrugated appearance. And I think something that people hear about a lot is that there's limited or no response in the lower body to those typical weight loss measures such as low calorie, low fat dieting or exercise. It seems to lose weight only in the trunk and not to the limbs of the lower body. So, oops, it didn't happen. What I want to have a little animation here is supposed to happen, that these symptoms here in the center are the ones that I think that you, as an oncology massage therapist, if you're working on this patient with lipedema, you would have the most effect on her. You can have effect on that non-pitting edema, on the pain, on the bruising, and on the skin and tissue changes. So that's what I'm going to focus on next when we talk about manual lymph drainage, a specialized technique for dealing with conditions like lipedema. So the sequence, if you are trained in manual lymph drainage, the sequence for lipedema is going to be different than it is for lipedema. And this is from the Foley textbook of lymphology, and they talk about a short neck sequence that you would do first, and intensive abdominal treatment. We pretty much, typical MLD sequence would involve working in the abdomen, but you might do it even more for someone with lipedema. And then you would treat the inguinal lymph nodes right at the groin, and then you would do the legs and the buttocks straight up to those nodes. And the same thing, if their arms were affected, you would straight towards the axillary lymph nodes. A lot of times we don't need to establish those anastomoses. For instance, I could take this fluid from her legs and take it up to her axillary lymph nodes. But if I'm dealing with mostly fat and not a whole lot of fluid, I can just go straight to those nodes and not do that other pathway up to the arm. So, but if they also have a lot of lymphedema or a lot of fluid, particularly a lot of times it will be in the lower leg, then you may want to use that anastomosis. So it depends on your patient. And then typically we're using firmer pressure with our lipedema patients, but it's really to their tolerance. Because if they are one of those people that are extremely hypersensitive and have a lot of pain, too much pressure can cause discomfort. It can give them more bruising. And so you're having to start generally with a very light touch, but then increasing your pressure as it's feeling okay to your patient. So how are we going to use manual lymph drainage for managing their swelling if they have some non-pitting edema associated with their lipedema? So manual lymph drainage, we know it moves fluid out of a congested area. We're using it to activate those lymphatic vessels and move fluid out of that area. It increases the absorption of fluid into lymphatic vessels, and it actually can increase the contraction rate of those lymphatic vessels. So they're going to pump faster. I don't know if you've seen these really awesome videos using IC green. This is a patient with breast cancer related lymphedema in her arm, and she's been injected with the dye, the IC green, that visualizes lymphatic vessels as much as 2 centimeters deep. So it's not going to get those really deep vessels, but more of the superficial vessels. And we can see here is a vessel right here. And so I'm going to start that video, and you can see, I mean, the video is going, you can see, but there's just like, there's no movement here. There's nothing happening. Oh, barely just starting to get something. So now we start doing MLD, and let's see what happens to that fluid. So can you see that just with our manual lymph drainage techniques, we are having an effect on those lymphatic vessels. We're causing that fluid to be transported out of an area that's congested. So how can we use manual lymph drainage or even your regular oncological massage techniques? How can they help with pain? So there was a very small study on women with lipedema, and they were comparing using complete decongestive therapy that included manual lymph drainage and with just using skincare alone. And they definitely had much more reduced pain by doing the CDT. Healthy subjects, they actually compared their pain threshold and their pain tolerance before and after a session of manual lymph drainage, and it improved their pain threshold and their pain tolerance in those healthy subjects. And this last study I talk about because of fibromyalgia. Quite often, women with lipedema are misdiagnosed with fibromyalgia. And so this was, I thought, had relevance to women with lipedema, that they had significant pain relief with manual lymph drainage. How does it reduce the pain? Well, there's lots of theories and we're not really sure. But one possibility is that because we're facilitating the transport of waste and toxins from the tissues, we're probably reducing the inflammation in the tissues, which is going to help reduce pain. Another study, they hypothesized that just the manipulation of the tissue helps interrupt those pain pathways of delivering that pain message to your brain. And so that might also be what's happening with manual lymph drainage. So let's talk a little bit about fibrosis, because there can be a lot of fibrosis in the tissue that is affected by lipedema. And so fibrosis it occurs when normal healthy tissue is replaced by connective and scar tissue. And so it can become quite firm and stiff, and it tends to develop in those areas of excessive fatty tissue that is happening with women with lipedema. And so it can be those firm balls of fibrosis. So there can be grainy sized or walnut sized nodules, or it can be these tendrils of scar tissue that is throughout the fat. And those tendrils tend to be the ones that bind the fat and tend to make us look lumpy like cellulite, that mattress-like corrugated, uneven, dimpled look. And it can cause significant discomfort and limit their movement. So dealing with that fibrosis is going to be highly beneficial to your patients. And definitely it's decreasing the health of the skin underlying tissue, probably because one thing that's also impacted is the evacuation of waste and noxious materials by your lymphatic system. And so that's staying in the tissues, and it's really decreasing the health of that tissue. So how is manual lymph drainage going to help with the fibrosis? Well, in one study, this was actually a study done on women with breast cancer-related lymphedema, as many of the studies are. And the manual lymph drainage actually had made a measurable change in the tissue composition in the areas affected by fibrosis. So they could measure it and quantify that by doing manual lymph drainage, we decrease the fibrosis. And in this other study, also on women who are breast cancer survivors, they felt that manual lymph drainage could contribute to prevention of fibrosis formation, even from its starting. So they really advocate for that early use of manual lymph drainage to prevent it from starting. And then if they really have severe fibrosis, you're generally going to need a firmer technique than manual lymph drainage. So all those other hand skills that you know, you're going to bring those into effect when you're treating that person who has a lot of fibrosis, again, to your patient's tolerance. Not trying to cause pain, but you are trying to improve the health of that tissue by decreasing the fibrosis. What about bruising? And why does this happen with lipedema? Well, we're finding that women with lipedema have leaky blood vessels. And so it probably has a lot to do with the health of their glycocalyx. And so it's allowing what should not be coming out of the blood vessels, those red blood cells should not be coming out. The nutrients and the fluid should come out, but not the red blood cells. And so when that's leaking out, we're getting the bruising, and it's probably because they are leaky. And also another more recent study actually showed that the blood vessel size and the number of those capillaries was greater in women with lipedema versus the healthy controls. So they are more likely, if they're leaky, plus we have more of them, we're going to produce a lot more bruising. And there is a high incidence of venous disease associated with lipedema. We know we have several conditions, one of which we're going to talk about tonight with Ehlers-Danlos. We have several conditions that seem to co-occur a lot with lipedema, and venous disease is another thing that could be causing us to have those bruises in lipedema. So in this, again, this small study, decongestive therapy that included MLD, it had a reduction of frequency of the bruising in women with lipedema. So we seem to be improving the health of the tissue by doing manual lymph drainage. I think you all know about the impact lipedema can have on quality of life. So in this one study by Joanna Dudek in Poland, I think it was about 100 participants. It was an online survey, and they turned out that all of the participants had some level of depression, and actually over 11% had severe depression. In an earlier study that Joanna did, she found that how severe their lipedema symptoms were, it really correlated with their quality of life. And so more severe, they had lower quality of life. And in general, in another study, it showed that women with lipedema had, in general, a lower quality of life compared to healthy controls. So what can manual lymph drainage do for quality of life for lipedema? Well, in one study, it favorably impacted those who had psychological stress. So again, you're helping them deal with that chronic stress. It improved emotional functioning, and It reduced feelings of anxiety, depression, it improved sleep. Well, we know how important sleep is for the functioning of our brain lymphatics. Lipedema is considered a progressive condition. And so any way we can slow that progression or halt the progression is going to be beneficial. And there is a couple of studies that are really advocating strongly for the early use of manual lymph drainage to help slow or halt the progression of the condition. And I also show you this one study looking at women with breast cancer related lymphedema, and they really felt that early use of manual lymph drainage can prevent or at least delay the onset of lymphedema. And maybe this can also happen for lipedema as well. So best practice in our treatment for lipedema would be treatment and monitoring by a certified lymphedema or lymphatic therapist. And there is an intensive phase, which is complete decongestive therapy for 2 to 3 weeks, 4 to 5 times a week. And then they're transitioned into a maintenance phase. And in this, they're really taught those self-care strategies, that this is what they're doing at home to manage their condition. And then they're having those regular follow-up appointments with you to make sure they're staying on track and if they need more manual lymph drainage. So that is my stuff for today. I'm going to really quickly, I want to give you a sneak preview because I think I'm just about out of time. What I would love to speak to you about is central lymphatic dysfunction. So when we look at the central lymphatic, so here is the lymphatics coming out of the legs, meeting at the cisterna chyli, which is it's a sac that's about the level of your belly button. And this main lymphatic channel going up through your trunk and eventually ending up into a blood vessel up by your collarbone. So interestingly, only 20% of the fluid that ends up in this main channel that's transporting fluid is from your legs. The majority of the fluid is actually coming from your liver and your intestines. So if we are having a problem somewhere up here in your trunk, can you see what a huge impact that would have, especially on your legs? So what I would love to talk about is how you can recognize what might be a problem and can be done about it. And so some things you might look for is they have this unexplained swelling that seems to happen right after they've had any kind of surgery or treatment mostly in the thoracic cavity. So the swelling starts in the extremities, head and neck, anywhere in the body, but they had some kind of surgery or procedure to the thoracic cavity. And then the problem is it could be delayed for several months. It doesn't happen right after the procedure, so no one thinks that it's related to the procedure. And then when there's central lymphatic problems, it actually starts with abdominal distension, swelling in the trunk and in the genitals, and then later you get swelling in the legs. So typically with lymphedema, we know that it starts distally in the feet and kind of works its way up, but it starts opposite with this person who has a central lymphatic problem. And then they might get some problems with their organs, so they can end up with breathing difficulty, with GI disturbance, with pain in their trunk. And then they would notice that after they try to do exercise, their swelling gets worse, even if they're wearing garments. If they're using a compression pump just on their legs, their stomach is going to become bloated. If they're wearing compression garments just on their legs, their stomach is going to get bloated. And if they do any prolonged sitting or standing, their trunk is going to get bloated. And then you are doing everything you know you're supposed to be doing. They are being completely adherent, and the swelling won't go down. It's totally non-responsive. And lastly, there's some interesting blood work that could be an indication of this condition. Their triglycerides and their cholesterol levels will be hyper elevated. And the creatinine, that's kidney function and the liver enzymes, those will also be elevated as well. And I'll talk about all that kind of stuff if I get the opportunity to share this with you. Here is all of my references in case you want to look at any of those articles yourself. Thank you so much. I hope I was on time.
Oh, wow, that was awesome. All right. If I have anything to say about it, we're definitely gonna have you do that presentation, Leslyn. All right, here is my presentation, and I'm so happy that so much of what you talked about will help my presentation make sense. So this is basically me talking about what I did for my summer vacation, because I had the opportunity to present this poster in Rome, and this was at the International Scientific Symposium on Ehlers-Danlos and hypermobility spectrum disorders. And I know it might seem like that doesn't really have much to do with who we are as oncology massage therapists, but when you hear a little more about this patient, perhaps it will make it a little more clear. Ehlers-Danlos disorder is a connective tissue disorder. It is often a hypermobility disorder, although there are 13 identified genetic subvariants or 13 subvariants of EDS. And I think it's 12 of them that have the genetic identity, and it is just the hypermobile that does not yet have that, but I learned at the conference that will be coming very soon. So generally this is diagnosed based on these symptoms and these presentations, and the Beighton scoring system is more complex than just this pictogram, but you can look it up on the Ehlers-Danlos Society website and download a form that has check boxes. But these are what my patients tend to refer to as their party tricks, and most of them can do these sort of intensive extensions of their digits and their limbs. And unfortunately, that can lead to a lot of pain. So we've already talked about what lipedema is with Leslyn and at a previous presentation. And the interesting thing is that these two conditions often show up in my clinic together. So in this particular case, this is the poster itself. In this particular case, I had a patient who came in with a diagnosis of EDS and was discovered to initially have lymphedema and then to eventually be diagnosed with lipedema. And among the things that they have in common, and not everything is present in each patient with each diagnosis, our patients are so individual, but these tend to be inherited. I guess they are inherited, because if it's hypermobility that is acquired during lifetime, that is not Ehlers-Danlos disorder. If we're a gymnast from an early age, or I've got some hypermobility in my knees, that's not Ehlers-Danlos disorder. That's bad posture for many years, in my case. But they are connective tissue disorders. The soft, velvety skin that is a hallmark of EDS is something I've often noticed with my lipedema patients as well. With EDS, that skin is hypermobile. They can pull the skin on the back of their hand up a long way. It's kind of scary to see it. The easy bruising is present in generally in both cases. Potentially difficult wound healing. The joint hypermobility we mentioned, that can lead to dislocations, subluxations, pain, and a lot of these patients, as Leslyn pointed out, have GI issues. That's true in both of these conditions. Chronic inflammation, the potential association with postural orthostatic tachycardia syndrome. So my patients with either of these conditions, I want them to sit up slowly when they're coming off the massage table and make sure they have their equilibrium. Pretty much true for everybody, but especially with these patients. And the mast cell activation syndrome, I have to be very careful what kinds of tools, devices, interventions, tapes, and things I might use with a patient who has that. And I see that frequently in these. So this patient in particular perhaps will give you a better picture of that mattress-like appearance that Leslyn mentioned. She has, to me, she doesn't look particularly large. She was very generous to share these pictures. She was very uncomfortable about doing that, but she wanted people to be able to learn. But I didn't immediately recognize the lipedema with her. Of course, I've been learning about that over time, like many of us. But she came in with the Ehlers-Danlos diagnosis and had a emergency abdominal resection, still had a wound vac, and had developed lymphedema in her lower legs after that. And so what was interesting was we treated her with lymphedema. She came in never having had a massage before. She didn't know if she qualified for manual lymphatic drainage, if she would be appropriate for therapy. I found it interesting to have her say, do I qualify for lymphedema therapy? Yes, ma'am, you do. And in my setting as a massage therapist, I was treating her with manual lymphatic drainage. And based on her presentation, I worked in an integrative manner with a physical therapist, CLT, to get her that initial treatment for the lymphedema. So she received the multi-layer compression bandaging and her legs reduced beautifully. But she was intrigued with how much benefit she experienced with the manual therapy. And I think something that was reminiscent of what we might have to deal with as oncology therapists was she still had a wound vac in place when we were doing probably our first 6 months or so of treatment. And so there was a lot of having to be very careful of devices in the treatment room. Once she got the lymphedema under control, she transitioned to wearing compression garments and eventually to these micro massage type compression garments that are often more well tolerated and appropriate for our lipedema patients. That's what she prefers. So the method I used really was to start with manual lymphatic drainage because she had a lot of pain. She was in a post-surgical state. And as she received interventions between myself, her physical therapist, other massage therapists that in the community that had more availability, she started to notice that she really responded to deeper interventions. So a lot of myofascial release was needed. Scar tissue mobilization through myofascial release, and also very carefully with gua sha, with some gentle cupping, with the graded mechanical negative pressure, that's the Lymphatouch machine, but also using a wound vac in a sort of off-card kind of way where that was used to create that negative pressure over a long period of time. Kinesiology tape works for her if she's very careful with it, but she does have the mast cell activation and sometimes has a response to it. So you have to be careful with that. And then MLD is just super beneficial for her. And we always utilize MLD in her sessions, usually finish with some of that, often start with some of that. And, I've pretty much already stated this. The interventions reduced her pain, improved her function. She has less scar tissue. She's more active in her life. And this case study was written almost a year ago at this point. So it's been about 4 years since we started working with her. And she is a happier person today. She really wanted to share her story in the hopes that it will help therapists recognize patients, that they can help in this manner. So we know that patients with lipedema and also with hypermobility syndromes have pain, functional limitations, and we know as skilled massage therapists that we can help these patients. The calming atmosphere is going to help them. The manual techniques, especially if we're very careful in selecting the appropriate technique for the appropriate patient at the appropriate time, which is what we all are trained to do, can maximize their quality of life. This patient is still, I don't know if she's doing it twice a week anymore. She's got a lot of family things going on, but she stated that massage is what keeps her going. I wish that I had recognized when I met her that I was going to be moved to write this study on her, because I think using some published quality of life scales could have been very informative with her, but we did not do that. So anyway, that is my patient, my story. Let me stop sharing my screen and invite Geri to tell us about the resources that she has provided for us.
Thanks, Adie. And welcome to you all, and thank you for attending tonight's presentation. My part in this presentation is to highlight certain online resources for you all pertaining to our topics of the day. And I've done that in this PowerPoint and also in the handout that you will be receiving. Now, just know that our handout has a much more detailed list of resources for you. So we have about 30 for all of the topics that we have discussed. If you have any resources that you would like to add to our list, please send them to us and we'd be happy to add them. Okay, let's get started. Our first slide is about lymphatics. And this is such an interesting topic. On our first slide, I have highlighted a website called Society for Neuroscience, and it discusses the understanding the lymphatic system. This was written in 2018, and the material on this page has been adapted from one of their scientific training short courses. So take a look at it when you can. It's really very, very interesting. Moving ahead to the next slide. Here we have the National Library of Medicine, and the title is The Lymphatic System, A Beginner's Guide. Once again, this online article has a great amount of information along with diagrams and images related to the lymphatic system. Continuing on, our next topic is the revised Starling's equation. Here I've listed two different websites on this slide. The first one is the BGA, which is the British Journal of Anesthesia, and ResearchGate. The online article noted here in both is entitled Revised Starling Equation and the Glycocalyx Model of Transvascular Fluid Exchange, an improved paradigm for prescribing intravenous fluid therapy. This was written in 2012 by T.E. Woodcock and T.M. Woodcock. I think they're a father and son. And it gives detailed information broken down in sections. If you can, take a look at it, and you will see that you can also download this article, share it in an email, and also post it on social media. And once again, our handout has many more websites pertaining to this topic. Okay, our next slide. We're going to be talking about the glycocalyx. Here we're going to travel to the LEARN website, and LEARN is the acronym for Lymphatic Education and Research Network. Here you can read a blog from Dr. Andrea Brennan, who holds a clinical doctorate in occupational therapy with a specialty in lymphedema practice management. Her online article is entitled Revising the Starling Principle, the Importance of the Glycocalyx, Now, this article is the second piece in her 3-article series called Thinking Lymphatically. Take a moment to read this article, and inside it, you will see a link for the first article. All both very, very interesting. Moving ahead to the next slide about the glycocalyx. Here we see a chart that discusses the functions of the glycocalyx. This was found on Quora, and it was created by a former professor of histology, Ken Saladin. Kind of breaks it down. All right, our next one, Ehlers-Danlos syndromes. Now here I've listed 3 different websites for you to look at, but one thing I'd like to point you to is on the left side of the screen, the Ehlers-Danlos Society and the image of the zebra. And you might think, well, why a zebra? Well, let me give you a little background about it. Medical students have been taught for decades that when you hear hoofbeats behind you, don't expect to see a zebra. In other words, look for the more common and usual, not the surprising diagnosis. Well, the zebra became a symbol for those with Ehlers-Danlos syndrome and hypermobility spectrum disorder, because they are the unexpected. Sometimes when you hear hoofbeats, it really is a zebra. When you see a zebra, you know it's a zebra, but no 2 zebras are alike. They don't have identical stripes, just like 2 people who have Ehlers-Danlos syndrome or the hypermobility spectrum disorder don't have the same symptoms. They're both different in their symptoms, their types, and their experiences. So the identity of the zebra has now been adopted across the world through social media. And this is to help bring the community together. And here's a fun fact for you. A group of zebras is called a dazzle. Kind of cool. Okay, moving ahead in our last slide, we're talking about lipedema. Okay, and here I've listed a few websites for you to look at. The first one, Learn, was started in 1998, and it's a national and international nonprofit organization. It's really excellent for learning and support for patients and caregivers and medical community, just about everybody. And maybe you know Kathy Bates, the actor. Well, she's the spokesperson, and she became their spokesperson in 2014. Moving ahead to the lipedema project. Here, this website offers information and support to men and women, and they offer research and education about lipedema. The social resources page contains information regarding blogs and Facebook groups too, which are both national and international. Lipedema Simplified offers support, coaching, master classes, community membership, blogs, podcasts, and more on lymphedema, lipedema, and obesity. And the last one, Lipedema University. This website provides videos, audio podcasts, webinars, more areas of learning, and printable materials. So that ends our virtual learning journey. And with that, I turn it back to Gayle.
I want to thank let's see. Video, yeah. Thanks to the 3 of you for your dedication to this. And you know, you guys are like I know most of you guys on this webinar, and we all are so devoted to our clients and our patients. So thank you to the 3 of you, you know, for this extra time and helping to educate us. So I'm wondering, Leslyn or Adie, do you want to say anything else about Lipedema Simplified? Are you guys are both part of that, or the Lipedema project?
Well, honored to participate with Lipedema Simplified as, ostensibly a health and wellness coach, because that's another certification that I have. But I'm also, learning so much in my participation from Leslyn and from Catherine Seo, and especially from the ladies who, share their stories. And, so far I haven't met any gentlemen there, but the women who have shared their experiences have given me a lot of education. So it's really moving to participate. I'm very interested in what Leslyn has to say.
Well, I'm my principal association with lipedema is with the Lipedema Project, and it's a nonprofit that we focus on education and research, working on publishing articles and helping do research and stuff like that. And I kind of volunteer a lot with Lipedema Simplified as well. We just had a big event in October where we had Dr. Stan Roxon and Emily Eicher and a bunch of people speak. So it was quite a wonderful weekend virtual event. I just wanted to also, if I could share another resource. This is on the Close Training website, and he has a whole bunch of videos you can see. And I just love this one presentation that Dr. Baltazar did about the glycocalyx and how it's associated with lymphatic disorders. I thought he explained it really well, and I used it a lot for my information for my presentation. And he just explained it so well. So if you are would rather watch something rather than read an article about somewhat of a difficult concept, I'll put this page in there. You have to scroll down. So it's Close Training videos. And so you'll scroll down to this about the glycocalyx. So I'll put that in the chat, and some people might prefer it that way for learning about the glycocalyx.
Thank you. Thank you.
Yeah, many thanks. So we promised some time for Q&A, and we found it's easiest with a group of people is to put it in the chat. So let's just take a minute right now, and people could just type in questions. And Adie and Leslyn and Geri, you guys will be able to see these as well as I can. It looks like, and Kathleen Lyson has put in a lipedema standard of care document into the chat. Thank you for that. Ashley, can I just ask, while people are doing that, with things that are in the chat, how do we go back and retrieve those? I'm not that handy with doing that kind of thing.
I will be grabbing all of the links and putting them in the post-webinar follow-up email that we'll have, but also I can download the chat file once this processes. So
yeah, okay, thank you.
Fantastic.
Yeah.
And I will say thank you to those of you that posted an answer to my question. I could not see it while I was sharing my screen. And so that's why I didn't, respond to what you put. And then I didn't ask any more questions. I thought people weren't writing anything. So I'm so sorry. But several people said muscle contraction can increase interstitial fluid pressure and extra fluid in the tissues. And Karen said direct tissue pressure, like from massage. You guys are all right. Thank you very much for participating that way. I guess it doesn't work when you're sharing your screen.
It's a very knowledgeable, skillful group. So yeah, can you see what Susan has asked concerning diet and Foldy and Vader teachings that fasting combined with the MLD? How long should one fast?
So I have pretty strong feelings about fasting. And I subscribe to what Dr. Steve Finney and Dr. Jeff Volek say, and they say that there can be pretty strong concerns about fasting for more than 24 hours, and you really should be monitored with that. But there are some protocols for fighting cancer and doing all kinds of things that you might do a more extended fast. I just really think you should be monitored. So, doing fasting carefully. I think you can get the same benefit through carbohydrate restriction, because both fasting and carbohydrate restriction will generate ketones, which that's the benefit there, is that we're getting ketosis. So they're doing an interesting study right now out of Belgium with people with lymphedema and using a ketogenic diet and measuring the impact that it has on their lymphedema, both with volume and also doing a lymphoscintigraphy to see what's happening with that. And so they've had some preliminary results. I think the study finishes in 2023. So maybe we'll have some results from that study next year, and we'll have something more concrete, because mostly it's been in mice. There's been a lot of human studies with lipedema, but lymphedema, it's mostly been animal studies. So this will be one of the first human studies that's going to be looking at that.
Do you have any comments or about how that would go with oncology patients?
There is a lot of research with using the ketogenic diet and fasting for cancer treatments. So, and I would suggest, and I could put this in the chat, it's a look at the work of Dominic D'Agostino, South Florida University, and Thomas Seyfried out of Boston. And they've done extensive studies, mostly with brain cancers. And usually these are people where every other treatment has failed. And so they're the ones that would do a diet study. They are usually the ones that participate. There is some on breast cancer survivors. They're using a ketogenic diet. So there's if you just Google that, cancer and ketogenic diet, you're going to see a ton of work on that, and fasting. Thomas Seyfried says that it actually works better if we have caloric restriction along with ketogenic diet. It seems to have much more of an effect. It makes, if you're still doing chemo, it makes that stronger, makes you tolerate chemo better. So there's just a ton of literature on that.
Wow.
This sounds like a whole nother presentation.
Yeah.
Carolyn Tagg says, great presentation, and asks, can you speak to how many clients are actually diagnosed or know about lipedema themselves versus them coming to you and learning about it? Does that make sense?
Yes. Yeah. So, most patients they're self-diagnosed or have no idea they have it. Very few of them actually have a diagnosis, although it's getting better. Things like, Kathleen posted the standard of care paper, things like that are educating the healthcare providers, and it's much more known about. But most women just find out about it now by searching the internet and going, oh my God, that looks like me. That describes my symptoms perfectly. Or they will go to a lymphedema therapist thinking they have lymphedema, and the therapist goes, I'm not allowed to diagnose, but you kind of have the symptoms of lipedema. And then they will, go to their healthcare provider after that. So either they don't know they had it, they're self-diagnosed, or the lymphedema therapist tells them about it. That's the vast majority of our patients.
Mm-hmm.
And I think that as oncology massage therapists, we may be seeing people who have these symptoms that they find confusing. And if you've learned, something that gives you an aha moment with these presentations, you may not want to say to the patient, oh, I think you have lipedema, but you might want to, a technique that I use, and this may or may not be appropriate in your settings, but is just to suggest that they go to Lipedema Project or they go to Lipedema Simplified and see if something resonates for them. And then hopefully have an opportunity to guide them to a vascular doctor who recognizes that at Vanderbilt, or, you know, some other medical professional who will give them a diagnosis.
Jane, you've asked if there's a way to get a copy of the first webinar, and yes, there is. Ashley, could you put that link to the one we did last spring, when you send out the follow-up email in a couple days? That would be excellent. Amy Tyler is apologizing. She got her time mixed up in Sydney, and I never configured that out, Amy. So yeah. Emmanuel says, can anyone talk a little bit about vibration therapy for the lymphatic system? My clients are asking me about it, but I don't have experience with it.
Leslyn,
I think you got a lot with that, Adie. Go ahead.
well, I mean, the vibration plates seem to be helpful for people with lymphatic dysfunction, I would say. It's and like anything else, it has to be dosed and appropriate for the patient. So just jumping on a vibration plate is probably not a good idea, but more about vibration plates, going into short bouts of time with them, does seem to be helpful for people to reduce the pain and swelling with lymphatic dysfunction in many cases. Our lipedema patients, on Lipedema Simplified, the members talk a lot about how much they love their vibration plates, but some of them have found them to be uncomfortable, itchy, increase pain before it reduces it. And then there are, you know, certain physical concerns that you have to take into account before getting on them. So you want to make sure that it's appropriate for you.
Thanks, guys. Kathleen License says, I found a client that came to me after liposuction, had lipedema symptoms, and sent her to a special plastic surgeon for diagnosis. Most of my lipedema clients already have a diagnosis from Dr. Herbst.
Yeah.
Yeah. Susan
Yeah,
was
I mean,
yeah.
I'm in a chronic pain and chronic illness setting. And so, you know, a lot of patients come in there with obesity and feeling terrible because they've tried so many things to address it. And then hearing maybe there's a reason that this is happening that doesn't have to do with your lifestyle choices, more has to do with something that you inherited. That they find that reassuring. And the question is, can we get them to a doctor who can give them a good diagnosis?
Ashley, can you add this resource that Elizabeth Ryan has put in the chat into Geri's listing so that we all have that?
You got it.
Yeah, got to get that.
Yeah.
Looks good.
Thank you, everybody. So I'm noticing it's 5:59. You can't get much more on time than that. I say let's call it for tonight. We have our last webinar for this year scheduled for December the 8th. Ashley will send out an invite probably in a couple of weeks for that one. In that link, there will be information. Well, I think in a couple of days, actually, won't you, Ashley? You'll send out a link that includes a PDF of the slides, a link to the recording, how to take the quiz if you would like to get CE credits. You have my apology. I'm the one that has to jump through the NCB hoops and get this approved. And it's difficult to do that 6 to 8 weeks ahead of time. And so I'm just going to shoulder that one. But as you know, if you've done this before, it's like, it's better to take the quiz ASAP while you remember stuff. You can take it anytime. And then as soon as NCB approves us, Ashley will quickly send you your certificate for this. But my apologies for not getting that done pronto. The last thing I want to remind you about is we get to meet again for the first time in 5 years at the Oncology Massage Healing Summit. That's in Minneapolis, and it's April 21st, 22nd, and 23rd. And Nicola McGill, who many of you know, will be doing a breakout session on disruptions, lymphatic disruptions from head and neck cancers. And she's also going to do on Sunday a post-conference, a full day on that same topic. So lots of good things, but since we're talking about lymphatics, I'll just remind you that Nicola will be back because she was really popular last time. So it's going to be really good to see everybody in person, first time in 5 years, you know, since it'll be 2018 since we've all seen each other.
Yeah, that's right.
So many thanks. Thanks to Ashley for holding us all together on this and for all the hard work that we're all doing. So bye for now.
Thank you all for this
Guys on the
opportunity.
Yeah.
Thank you. Thanks, Leslyn, for joining us.